So if someone on the floor has a question for the speakers, why don't you come up to the microphone, identify yourself, and ask a question. So if there are no questions from the floor, in the meantime, okay, please.
Omar Ghanem, I'm a fellow at Mayo Clinic, Bariatrics. I have a question. Dr. Aurora mentioned multiple risk factors that cause gastrointestinal ulcers after bypass. The question is, how does the panel screen for these risk factors pre-operatively? And is a positive history or a positive test or screening change your operative planning, sleeve versus bypass? Thank you.
So I'll start on that one since that was my topic, but I definitely do screening for smoking and make sure that they do a smoking cessation program. I will actually do a urine nicotine test preoperatively to confirm that they're not smoking before I will proceed with a bypass. I actually want that to be negative before sleeve too, but if they've had a real struggle, I know that they're going to be at high risk to smoke again, so I definitely will sway that conversation towards sleeve in those patients. We do a preoperative endoscopy on our patients and a biopsy, so that's where our H. pylori comes in, and we'll treat that preoperatively. The aspirin and nonsteroidal use is based on medical history with cardiac history and joint pain symptoms, and again, that's one of the things that may sway me in my practice towards recommending sleeve.
So John, let me ask you a question. This patient now that Rory is talking about, is losing his insurance, is changing jobs, is telling you, Dr. Morton, I stopped smoking 2 months ago. I'm losing my insurance. I want the gastric bypass. You do a nicotine urine analysis, it's positive. What do you tell the patient? You're not going to do it? Do we have really the evidence to tell them that because of that positive nicotine test, you're not going to do a bypass?
It's a tough one, because there's a compelling need to decrease their weight. That's probably the two biggest risks for people's health are their weight and their smoking. So I'm like Rory. I tell them, you got to stop smoking. I'm a doctor. If I'm going to help you with your weight, I'm going to help you with your smoking. There's definitely a pretty big risk involved with smoking when it comes to not only ulcers, but wound healing, how the lungs work. It really depends on PAC-year history. If these patients have a PAC-year history more than 15 years, they tell me they frankly have tobacco addiction. Those patients I'm going to be a lot stricter with, but 15-year PAC history will be my determinant. I was just going to mention one thing about choice of operation. Like Rory, I scope everybody ahead of time. If these patients have grade C esophagitis or higher, I'm going to steer them towards a bypass. I know it's a conversation that takes a little more time, but it's worth it. You'll have a patient who's more satisfied.
Rory?
And as much as I'm a stickler to that smoking, I know there are people in other countries where the smoking rate's higher than in the States that actually do bypass successfully and don't seem to have a much higher marginal ulcer rate, but that's my personal bias, and if I can cut down on any risk, I'm going to do it.
So Nin, you're gonna turn down my sister who I told you lost her job, lose insurance, she's still smoking. Do we have the evidence to turn her down for bypass?
Yeah, I think so. We have an alternative. We have a pretty good operation, the sleeve gastrectomy. So for the patient who's smoking, first of all, I think anybody who undergo bariatric surgery should have smoking cessation. So I think that's just, for all comer. But particularly, the people that, are prone to actually smoke after bariatric surgery. So you have to be, take that into account. If that's the case, then I would lean towards the sleeve gastrectomy.
So Dr. Jones, you found out that my sister that is losing the insurance and wants the operation not only is a smoker but has also esophagitis. And we just heard from the experts on the left side that they would not do a bypass, they would do a sleeve. Would you do a sleeve now? She's a smoker and has esophagitis?
Well, I'd like to do anything I could for your sister. But no, I think if you're a smoker, they're going to do better with the sleeve. The esophagitis is a problem. I want to make sure we've tried to manage that medically first. It could get worse. But I think the sleeve and getting the weight down is probably the way to go.
Dr. Zundel, any comments with my sister?
Yeah.
I don't
First,
have
if
a
your
sister,
sister, I will treat her like a queen for sure. I treat all of them like a queen. But let me tell you this. I think there is more evidence for me the effect of the reflux and esophagitis and the problems we can have with the sleeve. And I know it's opposite what they say, that the one from the smoking. So probably your sister, I will send it back to you for a diet and for alimentary habit behavior, because she need to if she's changing insurance, I'll do it for free, for sure. It's your sister. But what I'm saying is, we cannot be pushed sometimes for things that are away from our scientific. I don't like doing bypass for smoking, even that you hear people like Mel Foby saying that it's not a problem. Uh, and I don't like to do, but esophagitis maybe it's nothing. I will give it the treatment, see how it goes, study better the reflux, and see if really I will contraindicate the sleeve or not.
Thank you. Let's go to the microphone on the floor.
Thank you very much for this excellent presentation.
If you can speak louder
Yes,
and identify yourself, please.
Dr. Mehmet from Istanbul, Turkey.
Nice.
Thank you very much for these excellent presentations. I want to learn from you when we use stent during the acute leakage sleeve gastrectomy. And also, I need a recommendation from all the presenters. I had a patient, he performed Nissen fund application before 5 years, but now his body mass index is 49. He waits me. What you recommend for me to surgery of morbid obesity for his patients?
Okay. So,
Thank you.
Dr. Gwen, why don't we start with you with the stenting? I think that the question is, what kind of stent do you recommend? You showed us the covered stent. I think that's your choice, correct?
Yes. So I use the longest stent, and depends on these tightness of the narrowing. You have to kind of like judge what diameter you use. Normally, we use there's an 18 or a 19 millimeter stent, and it's the length of it's going to be 15 centimeter. We always use cover stent. There's some people says, maybe we should use a partial stent, meaning the upper part of the stent is uncover for ingrowth. I don't really advocate that. Whenever you have ingrowth, it's going to be very hard to take the stent out. So we always use a fully covered stent.
But Nin, you're an expert esophageal surgeon. I mean, it's my perception and observation that when you stent a leak of a sleeve and you put that stent across a G junction, patients are hurting, patients have reflux. But when we have a leak from an esophagectomy and you put the stent, they don't feel it. Is that your observation too? Are you
Well,
more liberal with stents after esophagectomies than after sleeves? When they leak?
Remember,
I know your
leaks
esophageal-
in esophageal surgery is completely different. There's no distal obstruction. The leak associated with esophagectomy is primarily related to ischemia. All the conduit has some relatively of ischemia associated with it. Some has more than others, and that's really the pathophysiology of leaks in esophagectomy. But leaks in sleeve is a little different, like we talk about. It's more of the distal obstruction. So you can't use a large stent and try to dilate that area immediately. If you do that, the patient is going to have severe pain, and we have witnessed that. So that's why I talk about the diameter of the stent is critical. So sometimes we even have to go as small as a 16 millimeter. It really depends on the tightness of that stricture. Like the one I show you on the video, that was, that stricture is probably like 8 millimeter. You don't want to go from 8 millimeter to a 19 millimeter. I would just use a 16 millimeter stent first, and then later you can actually upstage it, meaning to go to either 19 or 23.
So, John, we just heard the other question is what you do with a patient that had a Nissen and it's now gaining weight and comes to you and said, Dr. Morton, and I tell you something, you did an upper GI, and that esophagus looks a little bit dilated. So what do you want to do? When you do the bypass, when you do the sleeve, do you wait or you take them, and what procedure you do?
Well, obviously, the patient has reflux given his original diagnosis, and he had the Nissen done. There's pretty good evidence to show once your BMI gets over 35 or even 30 for that matter, that your Nissen is not going to work as well. The intra-abdominal pressure is going to overwhelm your new sphincter, so it simply is not going to work that well. I personally would do a gastric bypass in this patient. If they're having evidence of reflux, either demonstrated by endoscopy with esophagitis or any ulcers or any evidence of Barrett's, I would not do a sleeve. I would take down the Nissen for sure if you're going to do a gastric bypass. So you want to make sure that you get all of that fundus unrolled. But I would definitely do a gastric bypass in that patient.
Okay, so Dr. Pryor is she requesting a vote. Raise your hands. Who would do in this patient had a Nissen a bypass, please? Okay. And who would do a sleeve? Good. So in the interest of time, we're going to keep going. And we have Dr. Matar, who is the president-elect of ASMBS. And before you ask a question, let me ask you a question, because you are the Speaker of the House for Stretta and Reflux. So here you have this patient that Dr. Zundel presented us, had a sleeve gastrectomy, is 2 years after the procedure, has been taking PPI twice a day, 40 milligrams, still having that reflux, and comes to your office and said, listen, I want a bypass. Would you offer them a Stretta before you do the bypass? Do we have really the evidence to do that?
I think for completeness, I would offer all the options available and counsel the patient on.
What other options? Are there any other options?
So we mentioned Stretta, which is radio frequency energy to the sphincter. There's also the links. I don't know if you're familiar with that. It's the pearl of metallic beads that are placed around the sphincter. And we can always increase up to maximum medical therapy if the patient is averse to surgery. And then the surgical options are conversion to gastric bypass.
Okay. So go ahead with your question.
Yes, thank you. This is a question, Dr. Morton and the panelists. You know, internal hernias, as you mentioned, life-threatening. Even in the best of hands, they happen.
Yeah.
I personally close all my mesenteric defects, and it's very disappointing to see my own patients sometimes come back with an internal hernia. So have we learned, do you have any tips, any measures that can, I presume they're getting these hernias because the mesenteric fat is loosening and the sutures are loosening. Are there any tips for maximizing, for optimizing our closure of defects so that patients' incidence is minimized?
That's a hot question.
It's an important question because bariatric surgeries is life-preserving, it's life-affirming, where patients live longer after they've had the surgery, but this is a real risk for people after gastric bypass surgery. So when does it happen? It's generally about a year afterwards. When you look at it, it's people with very high excess weight loss. What can we do to minimize it? Closing it is one, for sure. I always use a non-absorbable. That makes a difference. Personally, I prefer to interrupt them. I believe in security. You know, if one of the sutures comes undone, if you run it, then you're out of luck. So interrupted will make a difference. I've seen some people use clips. I've even seen some people use mesh. So that's something else that people could try to help prevent it. I will say this, I don't think we're ever going to get it to zero. I don't think it's a technical issue about the closure. You can do the very best job possible, but it will thin out. What we always have to maintain is vigilance, because if anybody comes in with chronic abdominal pain, even if the CT scan is normal, I have a 3 strikes, you're out. If they've come to see us more than a couple of times for abdominal pain, then I will take them for a diagnostic laparoscopy. We have a paper coming out that shows the yield of that is about 50%. So again, it's, I think, important to always have that high index of suspicion.
Yeah. So Dr. Jones, I'm an expert lawyer, and I have to defend a surgeon who did a gastric bypass, didn't close the defects, and the patient developed a hernia, needed a bowel resection, and he's getting sued. And I'm asking you to defend that surgeon. I'm going to pay you $500 an hour for reviewing records, $5,000 for being in court. Do you have now a decision? Are you going to help me in defending the surgeon?
So the surgeon looks up, he sees a hiatal hernia and doesn't
No,
fix it?
internal hernia.
Yeah.
We're
Internal
talking about
hernia.
a small bowel. Changing the subject.
So the patient comes to the office multiple times with pain and nothing's done?
No, this is a patient that had a gastric bypass, developed an internal hernia,
Yeah?
and a bowel obstruction, and ischemia, necrosis, got resected,
Yeah.
and the surgeon who did the surgery didn't close the defects. So I'm asking you now, are you going to help me defend this surgeon or not?
No. I'm going to pass it back and let someone else defend
But
it.
I have this paper here that Dr. Rosenthal published in Sword saying that...
Oh, I'm going to call Dr. Rosenthal.
No.
I'm going to tell him not only can you go to Rosenthal,
listen.
it'll be half as expensive.
Listen, and that paper says that he has even less internal hernias than the paper that this other doctor published that says he always closes defects and has also internal hernias. So I can give you evidence, Dr. Jones, to help me.
No, I got it. Well, I think the question here is, what is the standard of care on closing mesenteric defects? Yes? And so I think if we want to know the standard of care, is what a reasonable bariatric surgeon would do in a similar situation. So let's find out. You have who would close your mesenteric defects when you do a gastric bypass? Now, to me, that looks like most people. So I think the standard of care is you're going to close defects, and I'm going to wish you the best of luck on the case, and I'm going to do my best not to go against you to give you your best chance.
I saved so many surgeons from those lawsuits. The truth of the matter is that those who claim that close the defects, some people close just the jejunal. How many of you close both defects, Peterson's and jejunal? How many close only one defect, the jejunal? Well, you know, there is also variation. Not everybody closes both. So those who claim that closed defects have the hernias. A lot of patients that we relaparoscope for several reasons have the defects closed spontaneously. So in my opinion, closing the defects doesn't prevent you necessarily from having that internal hernia. And the keys, and I think John mentioned that in his talk, is high suspicion, early detection, and you can blame the surgeon not for not having closed the defects, but for not having acted or reacted early on.
Yeah,
correct?
but
From a
you're gonna. I mean, the key is even if you close the defects, you can get the hernia.
right.
Good.
Okay,
Thank you.
so that's going to be a good argument for you. But if you don't even try to close them, and my question is why not? And if you're going to close them, we also have a feeling that you want permanent, silk suture, not absorbable suture. I think the standard of care of what a reasonable average surgeon does is they at least try to close the mesenteric defects at time of operation.
John?
I think, Raul, you did say it. There's evidence to show that, closure of it does not guarantee that you're not going to have an internal hernia. So technique-wise, you could make an argument about standard of care. Standard of care is in the eye of the beholder in many degrees about who the expert is. I recommend closing it, but again, the take-home message is it can happen even if you close them.
Yeah.
So you got to always remember that.
I agree. If you have a problem, www.raulsavemefromthislawsuit.com, and I help you. The lady, I think, has a question. If you can identify yourself, please.
Katie Urani.
Speak up louder because we can't hear you
Okay.
here.
Katie Urani. I'm in private practice in Denver Bariatrics. I had a patient referred to me that had an acute leak from a sleeve gastrectomy, which I stented. The stent unfortunately had to be removed early, and then she represented 6 months later with abdominal pain and a chronic leak. So my question is, and she had a stenosis at her incisura. So my question is, what's your experience with chronic leaks? Or can those be stented again? I will mention this patient had no bariatric benefits, so she would be paying out of pocket for anything that we did.
So why don't we start with Dr. Zundel, and each of the experts can comment on that.
First, this is much more common than you think. We have even patients coming 12 months later with undetected leaks, but they were there for a long time. For us, when you receive the leak at the first time, the most important thing is to look for another problem in the sleeve, because probably that's why we never close. So as Nin mentioned before, we need to make sure if there is a bad angulation in the incisura, a stricture somewhere, we dilate it at the same time, because it's never going to improve. Sometimes we were lucky that they put the stent past the incisura and it worked like a dilation, but once you remove the stent, the stricture is still there, or the angulation is still there. So we look for that defect. If it's not there, we dilate the pylorus also to reduce the pressure, or you can put Botox in the pylorus to reduce the pressure. But we put the stent. When they come back, our experience with the chronic leaks, if they were not well treated, we will treat it like it's the first time. But if they're well treated and they're chronic, I'm already preparing my conversion surgery to do something more aggressive, but we try. We try because at the end, you ended up doing almost a total gastrectomy with an esophagojejunostomy. That is still a big operation. So I will try it.
Nin, this was your topic. You want to add anything to what Natan said? And then we go to the next question.
Well, not all stent are created equal. So by you saying that, she has the stent previously doesn't mean that the stent was adequately used. So I think one thing I stress in my talk is that the stent has to be long enough to actually bridge the obstruction site. A lot of gastroenterologists don't do that. They don't understand the pathophysiology, and actually the stent is really proximal to that site, and that's not going to work. And whenever you finish stenting, you have to really reevaluate that area and make sure the leak is not still persistent. Because if it is, you can treat the stent again. Additional, you just need a little bit more time. But as a chronic leak, I think at this point, I think the only treatment is really, conversion this to almost an esophageal jejunostomy. Yeah.
Thank you. A question from
Masoud Rezvani, bariatric surgeon, Virginia. I have two questions for the panel. Number one, what is the panel's recommendation regarding the Peterson in BPD patients? Close it or not to close it? I personally have seen one patient with the typically doesn't happen hernia for the BPD Peterson, but I have had one patient that happened, but I typically don't close it. Still, I don't close it. Second question is that depends that how long we consider the common channel for the BPD patients, but very often it's very close to the Mickles in case patient has a Mickles. Recommendation is take it out, and if you do take it, basically it's going to be two staple lines close to each other, has a higher risk for the leak. So I appreciate it.
Rory. Do you want to start answering? Yeah. I'm sorry. We could really. It was difficult to understand your questions. Can you repeat that a little bit louder? We cannot hear the microphone.
The first question is regarding the Peterson and the BPD. Close it or not to close it? And
Closing Peterson, yes or no?
And the second question is that the Michel's diverticulum, which is close to the jejunal-ileoanastomosis in BPD patients, what do you do it? Because it has a chance always patient get a Michel diverticulitis, or the Michel is long enough, gets along the bowel and basically cause the obstruction.
Great, thank you. Rory.
So I don't do that operation, so let me preface that maybe I'm not the right person to answer that, but I would have resected the Meckel's, and I have reoperated on patients after that operation with internal hernias, so I do think that it's probably reasonable to close those defects.
Dr. Morton?
I agree with Rory. I've done 3 duodenal switches in my career, so I'm not a big-time expert on them. But I would take out that Meckel's for concern about down the road. And you can absolutely see internal hernias. I've operated on them, so I definitely would close them. Remember the risk factor for why people get them? Rapid weight loss, massive weight loss. That's duodenal switch.
Dan, do you close Peterson's defect, and would you resect Meckel's in a patient who has BPD?
I don't do BVD.
He doesn't do BPD, and how about closing Peterson's defect?
I always close Peterson's defect.
He's talking to me. He always closes Peterson's defect. Next question from the app.
Dominic Asman, I'm a resident at Kerr Medical in Bakersfield. Do members of the panel routinely use post-operative imaging to rule out anastomotic leaks? And if so, do you find that patients who are later found to have acute leaks had a negative upper GI series?
Dr. Zundel?
I use them. I never found a leak in my life in neither, but I use them for a couple of reasons. The first one is that they make the patient get out of the bed and go somewhere and stand and walk and whatever. And second, because it served me. You see, if I check intraoperative the leak that I think is the standard of care, if you check it the first day that I don't think is the standard of care today, but I check it. If the patient came with a leak later, I did all I could in the reasonable, it's legally for me doing it. For the sleeve, I'm not looking for the leak. I want to see how my sleeve look the next day. So when my patient come back in the future, I can compare it ourselves. So I keep doing it for all of them, understanding that it's a cost, but I haven't seen a leak in the next day in neither of both. Dan?
Dr. Jones, I have another client coming to me, and I need you to help me defend
I don't have
him.
time for these legal reviews, okay?
I'm paying you $10,000 if you come to court with me.
I have time for your legal reviews.
So here's the story. This patient had a gastric bypass done, and the surgeon did not do a leak test. And 10 days later, this patient appeared in another hospital, with a left upper quadrant abscess, was drained, and they're suing the surgeon because he did not do a leak test in the operating room. Is doing a leak test standard of care, yes or no? Should he have done it?
He did a leak test. He looked at his anastomosis. It was intact. He looked at it all the way around. Maybe he had his telescope in. Maybe NG tube with some air. Hopefully he looked at his anastomosis and was very comfortable with it.
Yeah, correct.
But do I blow up my anastomosis and with methylene blue and look at it? Yes. Is that helpful? Never. I've done thousands, and I've never found one.
So following Dr. Pryor's advice, raise your hand who does a leak test. Okay, so we should do it. Next question from Dr. Himpens. And go ahead, Jack.
It's for Dr. Zundel. 2 questions or 2 remarks.
First, Nathan, are you aware of that study coming from Vienna, an ongoing prospective study that demonstrated that after 10 years, 15% of the patients developed de novo Barrett's esophagus? And then second, it's more a recommendation. I've done 82 of those wraps, fundic wraps, in case of a bypass. I started doing that in 2006, so I have about 11-year follow-up. And I had to take 20% back down again for the simple reason that one, some develop late dysphagia. It's like the fibrotic ring that they develop. And second, a lot of them redevelop a hiatal hernia. And when you have a herniation of the whole thing, wrap included inside the hiatus, that's not a nice thing. So I want your comments on that.
Thank you, Jack. So the second, I'm learning. I haven't done it. That's what I present Kelvin's video, and I'm not pretty much convinced, but if it helps, it helps. But the second one, not only the study, there is also the Genco study coming, del Genio study. So my first disclosure is I disagree with this Barrett statement that is coming, but it's my personal opinion. Because I think Barrett should be a contraindication, not all of them. Maybe Barrett type 1 or in an old patient, senior, because we're getting all old, so I'm not saying old anymore, in a senior person. Maybe you can do something. But I agree with you. Study from Genco showed that after 5 years, you can still see with very good studies, endoscopy and PH studies, 56% of the patients after the sleeve still have some kind of reflux after 5 years. So that other paper from Vienna that is coming show me that Barrett more than ever should be a contraindication to do the sleeve. So I agree with you, and I agree with that paper.
Well,
so that's what I say, we need to be very careful a little bit with that.
I have to strongly disagree because the study from Vienna doesn't have pre and post-op endoscopy, pH manometry. They have only post, if I'm correct. And number two, the statement that came from ASMBS has nothing to do with Barrett's, has to do with reflux, which is different. We know that obese patients have a very high incidence of preoperative reflux, regardless. 40% of patients that are obese might have reflux. So the fact that at 5 years you do an endoscopy in a patient who had a sleeve and you see reflux, this is nothing, terrible. If you've done the pre-op EGD and pH and you don't see reflux, and 5 years after you do it, but we don't have that kind of study in the literature yet available. Nobody has done the job of following this patient.
But Raul,
correctly.
are we asking our surgeons like a standard of care should be do endoscopy before, or we are not?
Dr. Morton, a question and a comment to that?
I personally do think we should do endoscopy in these patients to see if they've got any sort of occult GERD sequelae like Barrett's or grade C esophagitis or higher. My comment was around the bypass. I think the reflux rates are actually quite low if you look at it. And it's important to do impedance testing to see what's coming up. Generally, it's not acid, it's bile, and it could point towards a short limb. That's something you got to look at. You can do a HIDA scan too to see if that's what's going on. And in that case, wrapping it may or may not help. Maybe lengthening it might help. So,
question from the floor.
Hi, Dan Wool, in private practice in Barrington, Illinois. And I have a question for Dr. Morton and the panel. My question to you is, what would you do with the intussusception at the jejunal-jejunostomy?
Dan, you were my fellow, so you know what to do.
I know what to do, but
okay.
So we had a patient who had an acute intussusception done at another hospital, open, and they just reduced it. And in conversation with her, I brought her back 6 weeks later and resected it. But I was wondering, there's not much in the literature about intussusception, and we don't talk about it, but I think we're going to probably see it more. So I was just wondering your expert opinion.
Well, thanks, Dan. But I think it's a hard problem, and we don't have a firm answer for it. I think obviously you want to reduce it to avoid obstruction. You do the usual things with any sort of intussusception. Make sure that there's not some sort of lead point that you're concerned about. What happens with bypasses over time, the biliopancreatic limb becomes quite atonic, and it becomes a safe refuge for the bowel to intussuscept through. Then the question comes up, what do you do with it? Simple reduction. Do you plicate it, or do you redo the anastomosis? And I think you got to get to either frequency of symptoms as well as severity of symptoms, how bad they are. Oftentimes, you're going to find this just out of the blue. Somebody gets a CT scan, they don't even have any symptoms, and they see an intussusception. That's going to be a more difficult thing about what do you do with them. In that case, I usually follow the patients, make sure that they're doing okay. Generally, what I'll do is I'll reduce it and placate it, and I will, redo the anastomosis if they have frequent and severe symptoms.
Dr. Pryor, you want to comment on that? This is a patient, that it keeps coming to the emergency room with CT scans showing intussusception, abdominal pain. How long do you wait? When do you operate? And would you do the same thing that Dr. Morton just mentioned?
So if they have recurrent intussusception, I think that's different. We see a lot of people who have a transient intussusception just because of the dysmotility in these bariatric patients. So one time, particularly if they're asymptomatic, I would actually just even re-image them, and a lot of times it'll be gone. And then you don't have to do anything. But if they keep coming back and keep having symptoms, I'd redo the JJ.
Thank you. Question from, please speak loud because the microphones are.
Sure. My name's Matthew Muslak. I practice rural surgery as a general surgeon, and it's about choledocholithiasis. I've helped our GI guys with lap-assisted
Get closer to that microphone.
ERCPs, and it's worked out well. But I have a new aggressive GI doctor, and he's placing an axio stent from the pouch to the remnant stomach, doing the ERCP, coming back 2 or 3 weeks later, pulling out the stent, and then endo-stitching the pouch closed. And I just kind of wanted to get what your thoughts were on that technique versus just a lap assist. You only put one hole in the stomach. Yeah.
Yeah, I didn't put it. I didn't put that in my talk.
Yeah.
And I think that's a pretty aggressive move, right? I mean,
I
I
agree.
probably would work with a different GI guy myself.
Okay. Who wants to comment on that? Rory?
So
John?
our guys at my institution also suggested that as an option. But if you look at the gastric fistula data, those things do not easily respond to any endoscopic therapy. I know I mentioned them in my talk. That's not a great option. So if they did that and it didn't heal well, you've really not helped that patient. So I would strongly advise against that approach.
So, Dr. Jones, this patient develops a gastric fistula, an ulcer doesn't heal, and is suing the surgeon. And I'm the lawyer. Are you going to help me to defend that surgeon in court?
That surgeon didn't know he was going to do that when he went to the GI suite, or he would have stopped him.
I think that's below the standard of care, big time. From the other side of
Yes,
you.
sir. Thank you. Marty Harnish. I'm a U.S. Army surgeon in San Antonio. For the manometrically confirmed achalasia patient who is morbidly obese and really, really wants a sleeve at the time of her Heller, a question for the panel. Would any of you offer the sleeve, or is gastric bypass the only reasonable option?
Okay, so why don't we start from the right side. Dr. Zundel.
I only have one treatment for those patients. I do gastric bypass with myotomy at the same time.
She had, what was her problem? Just
achalasia, if you want to sleep.
Achalasia and the patient wants to sleep.
Oh, achalasia. I'm going to pass. I have to think about that.
He has to think, okay. In the meantime?
I agree with Natan. I would do a bypass with the myotomy. It's kind of crazy when you think about someone who's morbidly obese with achalasia. It used to be the reason we did the Heller myotomy was because they couldn't maintain their weight, right?
Right.
Somehow or another, they're getting food down.
We've seen it. Yeah, go ahead, Rory.
Yeah, so Marty, you were my fellow, and I think we actually did some of these operations together, and we even talked about the IB achalasia shirts on those gastric bypass patients.
Nin, any comments? Yeah, I tell you, the big question is it achalasia with or without megaesophagus? Because if it's with megaesophagus, you might need that remnant, that stomach, to breach the esophagectomy. So in that case, the sleeve is a no-no. But if it is achalasia without megaesophagus and the patient is adamant about that and has, a total proctocolectomy, then the question becomes, should I do everything in one step or should I do things in 2 steps? And I've chosen to do things in 2 steps. I would do my Heller's myotomy, see how the patient does. You need a toupee or you need a door. And that brings also the next discussion. Should you do a sleeve? How are you going to do that if you need a toupee or a door? So the gastric bypass becomes their paramount. But hey, in the era of poem, who cares about reflux after myotomy? Question from the other.
She's a lady. So.
Yeah.
Sorry.
Ladies
Hi.
first.
I'm Kay Yancey. I'm doing private practice in North Carolina, and I have a question about hiatal hernias. Incidental hiatal hernias that are small that you find on patients you plan to do a sleeve. So you can either not fix it, you can do a full posterior mobilization and fix it posteriorly, or you can do anterior suture repair. So what do you guys recommend?
Okay, why don't we start? And John, you want to answer?
Well, we'll see this a lot. The one thing I'm going to tell you is if you have to check it beforehand. You know, if you don't check it beforehand, number one, you're not going to get reimbursed for doing any of it. It depends on the size of the hernia. In my opinion, if it's more than 5 centimeters, I'm probably not going to do a sleeve. If I'm going to fix a hiatal hernia, I'm always going to do a posterior repair. I think the anterior repair is not going to do much at all. But one really key thing, particularly when it comes to making sure you get paid for your efforts, you have to document it ahead of time or have some sort of evidence that it was pre-existent. Unfortunately, people were coding it with every single case they did, and that's what led to this need for pre-op documentation.
Dr. Jones, what did you decide with the achalasia patient, and what would you do with a hiatal hernia on the sleeve?
So the achalasia patient, I would have called you in Cleveland Clinic. And,
Okay.
So I'm not biting on that one. It just doesn't make sense that you have a patient with achalasia who's really heavy. In terms of reflux, I think if they're symptomatic, you're going to do a workup and you're going to detect a 5 centimeter hernia. So I think the one she's talking about is the little dimple, the 1 or 2 centimeter hernia that you find, and I would just put 1 or 2 stitches in it anteriorly and continue.
Great. Question.
Yes, I'm Dr. Kelly from Mexico. I have a question for Dr. Morton. I have a patient coming to me in 2 weeks. She's coming from Michigan. She has a Lynx anti-reflux device who has failed, obviously, because she's coming to me. And she's going to have, I'm going to do a Roux-en-Y gastric bypass. Would you leave that device in place or take it out?
Well, bienvenido. I think I would take the links out. I don't think I would leave it in. My concern would be around erosion over time. I know that the data around links is very low for erosion, but I don't think there's going to be much of a need for the links afterwards, because the bypass is going to render you the best anti-reflux option there is. So there's no need for it anymore, and I would remove it.
Dr. Pryor?
So if she has no dysphagia symptoms, I would leave the links. So I'm going to argue the other side, John, on this one. It increases your risk of that operation if you're taking it out. It's actually, you have to dissect the capsule on each of those beads, so it's not just a no-brainer removal like a lap band removal. So I would leave it. It's only going to help. If she has reflux later, then you're going to be kicking yourself that you pulled it out too.
Nin, you want to make a comment?
No, I think I will leave it. Just like Rory said, it's not that simple to actually take it out. Yeah, so you can cause injury.
Thank you. Next question from the floor.
Bruce Jones from Arkansas. I have 2 questions. One is, if you have that leak patient, it's an acute leak, and you put a stent in, and you get a GI a day or 2 later, and you're hoping to send the patient home with a diet, or maybe not, but you get a GI a day or 2 later, and there's a little leak around the stent. It's in other words, you still see the fistula. So do you just accept that, or do you need a stent on top of a stent, or how do you handle it? That's one question.
So why don't we start with that question, Nin? It's your turf.
The question?
Yeah.
Go ahead, repeat the question.
The question is that you do a sleeve, you have a leak, you put a stent, you put the dye, and you still that it's leaking a little bit towards the spleen. Speak to the microphone, because we cannot hear you here. Can you please make sure that microphone is
You
live?
can still see the leak.
Yeah, I think
You
I
still
think
see the leak. What do you do with that stent?
Your question is that when you do the upper GI, you still see a leak. Is that
Right, there's still see a leak. It leaks. There's a little bit of dye that comes around the edge of the stent on the upper end, and it goes through the fistula.
Yeah, I certainly that's a possibility. Sometimes the stent doesn't really fit and conform exactly to the size of the esophagus. Normally, majority of the time, even though there's a leak, is minimal. So what I would say is that you got to stay the course. The stay the course meaning NPO, IV antibiotic, so continue that route for, that predetermined length of time. And if that doesn't work, I would repeat an upper GI in about a week, and still it's leaking, I would take that stent out because that course is not working out, and I would evaluate the size of the esophagus. You might need a bigger stent.
Dr. Pryor and then Dr. Morton.
So one of my comments on that is Nin mentioned this really nicely, that the sleeve leaks happen because you have that downstream obstruction, and if your stent is treating that obstruction well, you've got a shot of that stent, even if it's still leaking, healing that leak.
John?
I don't use them a lot, but I think what you've described will probably be okay. I did have a question for Nin, though, about utility of upper GIs. Do you do an upper GI after every stent placement, day after?
Yes, so we do the day after, and then we do it 1 week. And if the 1 week the stent looks good, that's when we actually start the PO. So we keep them NPO for 1 week, and then at that point we assess, and if that's okay, we'll go ahead and start feeding.
Dr. Sundell?
Yeah, a short comment. I'm gonna ask Nim because we have a different experience. I don't do it the first day because we noticed that almost 100% of them for 24, 36 hours, you see that they're still leaking because the stent will accommodate and expand when it's inside the leak. So we wait for 2-3 days, and the most important is the one that Nin mentioned that you do later. So that's not your experience, Nin? Your experience is there are all no leaking the first 24?
You have a second question, correct?
Yes, I do. For that chronic leak, I think at the ASMBS meeting, it was talked about quite a bit, bringing up a roux limb and hooking to the leak rather than doing the esophageal jejunostomy. Is that falling out of favor, or is that still a good option?
I don't know if Dr. Himpens is still in the audience.
Yeah, he gave the talk.
He's the one that promotes the leak jejunostomy anastomosis. I personally do proximal gastrectomy and esophageal jejunostomy. I think it's healthier, it's simpler. Nin, what do you think? Chronic leak?
Yeah, I know. It's really depend on what you find intraoperatively at that particular scenario. You're not going to be able to kind of figure it out in each scenario, because a lot of time when you get in there, everything is chronically inflamed, and then by the time you take down the fistula, essentially it is ischemic. It looks bad. You don't want to hook a roux limb to that area. That's not what you want to do. You're just gonna have to resect that entire area and do a fresh tissue anastomosis, which is the esophagus. So yes, I think if you take it down nicely and you think it's a defect, yes, of course you can just try to hook up a roux limb to that. So we're not saying you can't do it. I think that decision has to be made intraoperatively.
So Dr. Morton, this patient now that had a leak jejunal anastomosis is coming back to you a year later with a terrible marginal ulcer because, from the sleeve, all the acid is going not only into the esophagus, into the jejunum too. So what do we do now with that? That's the real mess.
You have to get back to healthier tissue. If that means going more proximal, that's what you have to do. So the original operation was a sleeve converted to a bypass, and there's still an ulcer from it?
Well, it wasn't a conversion to a bypass. You have the sleeve with a leak, and you just bring a roux limb. That's the operation that they're promoting. You don't need to bypass that.
Yeah, I don't know. I don't know about that. I've heard it described. I don't know how well it actually works. But if you have a chronic leak in a sleeve, and we need to go through definitions of leaks. There's early leaks, less than 6 weeks, intermediate, 6 weeks to 3 months. Beyond 3 months, if there's still a leak, utility of a sleeve, of a stent, or placing that limb up there is going to be low. That's what I've seen, and I got to say the only thing that really helps them is, as Nin described, to carve back to where there's healthy tissue and give them potentially an esophageal jejunostomy. That's really what ends up helping them. And I'm not going to say it's easy. It's a sticky wicket to be up there because there's usually some sort of gastropleural fistula, but that's going to be the best thing ultimately for them.
Rory?
So I think you're in a unique situation with this patient, and I've not done this operation, but if that patient walked in my door when I get back next week and they'd had a sleeve with a proximal leak, had a roux limb that healed up just past that GE junction, I think I would just divide the sleeve and make it a gastric bypass.
Question from the floor.
Hi, Perlma from Fresno. So I've been working up some patients, and I'm finding some pretty severe gastroparesis that was not diagnosed previously. And so some of these patients have symptoms of nausea and chronic abdominal pain as well. So I've pulled my partners as well, and some are saying, you know what, just take the remnant, do a remnant gastrectomy, take it all the way to the duodenum, and everyone agrees to do a gastric bypass on these patients. Some people just say do a fundectomy and leave a G tube in place. What are your thoughts on this?
Who wants to comment? Dr. Suntel, do you want to start? Dan Jones?
Yeah, I kind of agree with that one. You know, for me, this kind of problem with the motility is one of the most severe that to make a decision what to do with the patient for two reasons. First one, because you need to check there is not this motility problem in other part of the intestine. So you need to check this patient has not a problem going to the restroom and he has no problem with the colon. Because at the end, if the disease is all general, I wouldn't do anything. But if it's the stomach, I like to remove the whole remnant and do a bypass. I think it's the best one, and the smaller the pouch, the better. And my anastomosis at this time, I understand that weight loss is the most important thing. For this patient, it's not the only thing. My anastomosis is a little bit wider for those patients. Thank God, are very few.
Yeah, I mean, real severe gastric paresis, diabetes, you know, whatever is causing that. I think the sleeve may not be the best way to go. The gastric bypass sounds better, but I'm not quite sure I want to take out the rest of the stomach and add that mortality.
Any comments from the other panelists on that?
I'd like your comments, Raul, because you actually are a gastroparesis expert.
That's right.
Well, you know, we look for gastroparesis in male diabetics that have been for a long time, diabetics, and we always look for those specifically so that we don't do sleeves on them and we do a bypass because obviously you bypass the paralyzed stomach with the operation. We don't do a gastrectomy on those because the stomach gets totally disconnected from the mouth, from the upper GI tract. You don't have air, you don't have saliva, you don't have food, you have nothing. So it really collapses. And it keeps always the door open for tube gastrostomy. Some of these patients have a serious dysmotility disorder. We see a lot of those that show up later on. And you have a big problem with someone that has dysmotility disorder and you have a Roux-en-Y system there. That remnant gets big and there's no way to decompress it. So I would promote in those patients really to do a gastric bypass. We don't put G-tubes routinely anymore. That's history of humankind. Thank you. Another question from the floor?
Ryan Lehman from St. Louis. I have two questions. So I want to know how each of you closes your mesenteric defect. Do you do it from the crotch up to the bowel or the bowel down to the crotch? And Dr. Morton, when you start from the cecum in your internal hernia explorations, do you start on the patient's left side and close the defect from that side?
So I close from the bowel down to the crotch. That's how I close it. And sometimes you can get a little shortening there that might make it more difficult to bring the limb up, but you just have to account for that as you're deciding to put the limb up towards the pouch. And then in terms of the reduction, I will go to the patient's left side for the reduction, and I will go to the patient's right side for the closure. That's just how I do it. And the way I set up my ports, it's like a box configuration, so it's easy to go in either direction.
So I'll close my internal hernia defects from the crotch up. On the JJ, I think it's easy to do either way, but I think it's really important to splay the mesentery and make sure your sutures are close enough together that nothing can get between a fold. I do an anti-colic, anti-gastric rulum, and I think there's some different ways that you can do that defect, and I really try to skew my closure up so I'm taking more colon down and pushing the rulum more up to kind of minimize tension, but I start again in the crotch there, which is the hardest thing to see, and work up to where it's easy, up to the colon.
One other quick mention, some people use fibrin glue. There's nature's fibrin glue, which is a little bit of blood, you know, and oftentimes it does happen. I always tell, you know, the fellow, like, that's okay. It actually is going to help for the closure. So.
Any comments from there? Question from the aisle. Yeah, go ahead, Mark.
Mark Pleatman from Detroit. My question is regarding the pre-op endoscopy for diagnosis and treatment of H. pylori. In asymptomatic patients, you would still do that, and wonder whether you have to wait for them to have the H. pylori cleared, and whether there's any data for that as opposed to just checking the specimen and treating him postoperatively.
Dr. Zundel, does H. pylori matter to you?
It's supposed to matter for the bypass, but I will tell you, for the sleeve, I don't care. But let me tell you this, you are totally right. We check for H. pylori, we treat them, and we never check if it was treated. So there is an inconsistency there. But for the bypass, I care. I think it's insignificant.
Dr. Jones?
Agree.
Well, the truth of the matter is that if you check antibodies for H. pylori in blood, it's going to be positive for a year or even more. So the post-treatment check is useless for a long period of time, and that's the reason we don't check after treatment. The other reason is because it is successful in 82% of the cases, so it's rare that they will persist. The third reason, we do so many sleeves and so few bypasses nowadays that I think it's irrelevant in the sleeve patient. Question?
Hi, Ellen Morrow from Utah. I have a question for Dr. Morton. On one of your slides, you showed pictures of the orientation of the roux limb. Is there evidence that the way you set up your roux limb changes your risk for internal hernia?
Thanks, Ellen. Appreciate it. There is no evidence. There is some belief that if the terminal end of the roux limb points towards the left shoulder, it'll lie flatter, but that is strictly anecdotal. There's no real evidence to say that one direction versus another will render any sort of benefit when it comes to reduction of internal hernia. That's just an anecdotal view. I don't know if anybody else has any thoughts around it, but it doesn't seem like it matters. But from the people, if you talk to a few people, they'll say make it point towards the left shoulder.
Last question.
Peter Gorecki, New York. A question on bypass and biliary dyskinesia on those very rare patients, sort of social disasters that they take opiates. You took the gallbladder out, they have normal LFTs, marginally dilated CBD, normal MRCP, no internal hernia. Have you ever go back and do sphincterotomy on those to, in last resort, hope that you may improve their symptoms? Obviously, you know, addiction problem and cessation of drugs is important, but it usually doesn't happen.
If I heard the question, there's somebody whose HIDA scan is negative?
Correct.
And somebody whose CCK would be negative, for whom you've done other tests and you can't find anything else.
If you believe in a study and its validity, yes, but negative.
So the idea is if all else is negative, take out the gallbladder.
No, the gallbladder is out long time ago.
Yeah, right upper quadrant pain.
Yeah. More complex, which is going back and doing
So I think there are patients that have pain in the right upper quadrant and left upper quadrant, maybe from ports, maybe from stitches, maybe from their stomach, maybe from ulcers. You know, I think you can do diagnostic laparoscopy and take a look as a possibility, as one thing maybe you haven't done already. But I think a slightly dilated duct would be a normal finding after a gastric bypass.
We have a series of 11 cases we are publishing on patients that come with right upper quadrant pain, have no gallbladder, and the key here is when they come with pain, you need to get the LFTs. If the LFTs are elevated, you have a good reason to go do a transgastrostomy papillotomy.